Good afternoon. I'm Claire McAndrew. I manage our marketplace work at Families USA, and I'm here to kick off our plenary on improving the marketplace for consumers. I'm really happy to be here because we have a fantastic panel who's going to talk to us about what I think is both the most exciting but also the most challenging part of the Affordable Care Act, which is implementing the marketplace in every state in a way that works for consumers. So we're almost 4 months into marketplace operations, and we really have a lot of success to celebrate. We learned on January 13th that over 2.2 million people have selected a marketplace plan, and of those people, 79% did so with financial assistance. And although we still have a lot to do to increase awareness of the opportunities for coverage and the opportunities for financial assistance, thanks to the work of everyone in this room, that awareness and the enthusiasm for enrolling, I think in many places, is much greater than we could have expected. But we also faced some really great challenges this year, from website problems to pretty aggressive attacks from people who don't feel quite the same way we do about the Affordable Care Act, to worries about marketplace plan provider networks and premium rates. We've really had a lot to grapple with. We know that the Affordable Care Act and the marketplaces themselves are making health coverage accessible and affordable to millions of people, but we still have more work to do to make sure that that holds true for every single person in this country. But we're often reminded, and we have to remind ourselves, that this is a marathon, it's not a sprint. To implement something as significant as a marketplace in a healthcare system that is already extremely complex is not a task we can complete to perfection in 1 year or even in 5 years. And that's why today we're going to be talking with 3 experts about what's been accomplished so far in marketplaces, but more importantly, what work we have ahead of us to make sure that marketplaces can truly fulfill their promise to all consumers. So to help us think through issues like marketplace usability, health plan quality, provider access, and premium affordability, we have 3 very esteemed panelists with us today. The first is Anthony Wright. Anthony is Executive Director for Health Access California, a position he's been in for over a decade, since 2002. His accomplishments and those of Health Access are many, and they include fighting healthcare budget cuts and encouraging safety net investments in California, helping to pass innovative laws to ensure timely access to care and prevent hospital overcharging of uninsured patients, and of course, leading California's ACA implementation efforts, including the implementation of Covered California, the state marketplace. And I meant to say leading the coalition effort, but I slipped and said leading the actual effort. So, Anthony's also worked for New Jersey Citizen Action, the Center for Media Education, The Nation magazine, and in Vice President Gore's office in the White House. Our next presenter and respondent is Cynthia Crone. Cindy is the Deputy Insurance Commissioner in Arkansas, where she directs the state's implementation of their partnership marketplace. And you may remember that Arkansas was the first state to explore the partnership option. So there she's leading the development of the state's plan management and consumer assistance functions in the exchange through an inclusive stakeholder engagement process. And she's also critical to integrating the state's Medicaid expansion program, their private option, into the new marketplace. Cindy has many accolades. In 2013, she was elected to serve on the National Academy of State Health Policy, or NASHB, Healthcare Access and Financing Steering Committee. And Talk Business magazine named her as one of 7 women influencing health policy in Arkansas in 2013. On top of this, Cindy's a certified nurse practitioner. She has over 35 years experience advocating on public health issues that affect vulnerable populations, including individuals with substance use disorders. Prior to her current role, she helped define family treatment and continuing care for families in addiction treatment. So we're really glad to have Cindy here today. And then finally, we'll hear from Sabrina Corlett. Sabrina is a senior research fellow at the Health Policy Institute at Georgetown University. And there she directs research on health insurance reform issues as they affect consumers and patients. She focuses specifically on the regulation of private health insurance and the implementation of new insurance market rules under the Affordable Care Act. And personally, I'll say that she has provided invaluable support and knowledge to advocates here in DC. Before her current role, she was Director of Health Policy Programs at the National Partnership for Women and Families, where she was a key leader in national advocacy efforts to implement the Affordable Care Act in a consumer-friendly way. She's also served on the Senate Health, Education, Labor, and Pensions, or HELP Committee, as Health Legislative Assistant to Senator Tom Harkin. And she served as an attorney at the law firm Hogan Lovells, where she worked on HIPAA, Medicare, and Medicaid issues. So to keep things interesting today, we're going to do this Plenary as a discussion format to hear about how different marketplaces are addressing different issues. So first, we're just going to start off by asking each panelist to tell us a little bit about the marketplaces they're working on. So starting with Anthony, can you give us some background on where the California marketplace is at now? And given where it's at now, what you think the most pressing priorities are for this coming year in terms of improving the marketplace?
Thank you, Claire, and thank you for your leadership on these issues. Good afternoon. Who's here from California? They're not normally so subdued. So greetings from California, where it is 50 degrees warmer and we have a working website. I think people have asked me, how's it going in California? And clearly, as an advocate, we know deeply all the issues and problems, at a very fine, granular level. But I also have to say, we think we're doing pretty well, especially grading on a curve. There's a lot of progress being made, and I want to say, especially in context of the problems that we've had in California. I mean, we are the state with the seventh highest percentage of uninsured folks, the highest number of uninsured folks and so I know some folks in the red states are like, well, why do I need to listen to the red state folks might say, why do I want to listen to him? We may be a blue state, but we have red state demographics. In terms of the top 10 states with the highest uninsured rates, we're the only one with a Democratic governor. And so we have more uninsured people than Massachusetts has people, and so we really have like the burden of trying to figure this out. And we were pleased that one of the reasons why we have been in comparison successful is because we started really early. We had a big state health reform effort in 2006, 2007. We were the first state in the nation to establish a state-based marketplace. I would note that was under a Republican governor, who I think you might have heard of, Arnold Schwarzenegger. He might be on a Super Bowl ad next week. But that enabled us to do a couple of things. One is that we were very cognizant that we needed to get the IT done stuff, start quickly to get that done, because that was just a time, there's only two limited resources in the world, time and money, and you got to get the time, and so we started that very early. And number two, we made some key decisions in there, most particularly that we were going to be an active purchaser, and only a handful of states, even among the state-based exchanges, are truly selective contracting, active purchasing, using the bargaining power of the exchange on behalf of the individual consumers who are in it. And that led to two big advances that were announced last year. Number one is that the Covered California is using its negotiating power to fully standardize all the products in the exchange, so that it truly is apples-to-apples comparisons between all the platinum plans, all the silver plans. And number two, that the other announcement that came out was that when we released our rates, the Covered California really did negotiate with the insurers and through the insurers to the providers to get much more competitive rates than was estimated. And so, in fact, we had to even readjust some of the modeling because the rates came in lower than expected. Again, not that everybody, there were some people who saw increases, some people who saw decreases, but health insurance is not cheap, it's not easy, but this makes it cheaper and easier in general. And so what's the headline? So as of the new numbers that we had this week, over 500,000 Californians selected a plan by the deadline of December 31st of last year. As of last week, that number went to 625,000. About 75–80% are with subsidies, so that's 425,000 folks by subsidies. And so if you add that to the 584,000 folks who signed up for Medi-Cal through the Covered California portal, and the 600,000 people who are in an early expansion of Medicaid, we have now over 1.5 million Californians who now have new financial assistance to afford health care coverage in California alone. And so we obviously have a lot more work to do on open enrollment, and in terms of the work ahead, a lot of decisions were triaged to this year, and so we'll talk a little bit about them, which is fixing a lot of the issues that continue to persist. Number two is how to make the Covered California a real driver for cost and quality and value. And three, seeing if there's ways that it can be a platform for continuing to cover the remaining uninsured.
Cindy, if you can tell us a bit about Arkansas, what you've accomplished this year and what you see as top priorities for next year.
Sure, Claire, thanks. Am I on? Okay. Well, it's good to be here, and I'm really happy that I have a voice. I've been worried about that the last couple of days. And I'm happy to report that we too have a website that works. It's a federal marketplace website that is working. In Arkansas, we were the first to declare partnership. We were the second behind Delaware for a couple of days to get the conditional approval to move forward. And we said we wanted to do all that we could. So we were doing all the plan management functions, the consumer assistance functions, and as soon as partnership states were allowed to do outreach and education, we also did that. We stand to benefit as much as any state because of our demographics. Now, our whole state has under 3 million people, but over 500,000 of them are uninsured. We have poor health indicators. We have really a lot in the way of a very concentrated health insurance marketplace, so lots of reasons that we are poised to benefit very much from this. So our marketplace, first in context, as in California, we are working on a lot of health care and health system transformation, payment, quality. And so as we built the marketplace, we wanted to strengthen what was already going on and make that a part of it. So that's one thing in context as we talk you might want to think. And then probably what we're the most known for is our private option. So it's a way that we were able to expand Medicaid by using the premium assistance model to have Medicaid eligibles purchase among all the high-level silver plans in the marketplace or qualified. And every qualified health plan has to have silver, so there's choice of everything that everyone else between 100 and 150% would be choosing in that plan. And we saw that as a continuity of coverage move, that something we expected 138%. We would see a lot of people moving above and below, and we wanted them to be able to keep coverage, keep their providers, and not have any drop time. Probably one of the greatest strengths of our marketplace is our stakeholder inclusion. We have a very diverse and engaged stakeholder group. We had 2 major advisory groups to mirror that plan management, consumer assistance, advisory, and they have had offshoots of what turn out to be the key issues. So we've had network adequacy, quality, and then a continuity of coverage, which ended up being some of our even further breaks into private option working groups. We consider our model a certification model for qualified health plans. We are not doing competitive bidding, but we see this as a part of the continuum of active purchasing because we have regulations and standards that are beyond the federal floor, and so we did make, and particularly as private option came in, and starting right in the beginning, choosing a base benchmark plan different than what would have been our default and adding criteria for certification. We ended up with 4 medical carriers. One is a multi-state plan. We have 71 plans, 4 standalone dentals with 24 plans. We have a very robust consumer assistance on the ground, which is very important because our very effective outreach education was halted the day before open enrollment when our legislature stopped the contract. So though we had funding, we had no air cover. We lost our outreach and our media. So the 500 or so guides that we have on the ground, plus many licensed producers, are now a couple hundred certified application counselors and navigators, all of whom had to be licensed and trained by our state law, are working, and they are doing really a good job. I would say that our priorities moving forward will be certainly to work to garner and sustain political support. We need to get back that media and outreach campaign. We need to be able to sustain private option and, just improve as we go forward. We need more competition. We not only want to increase the number of carriers, and we'd like to have another multi-state plan at least, but we'd like to increase the coverage areas of the carriers that we have. So we have new service areas, and 2 of our areas only have 2 carriers. We'll be working to really this year, I think, define meaningful measures so that we can monitor and begin to see how to adjust and improve what we're doing, design and really work on our quality, and we'll talk about that more later. That's what I think this is all about. And then in Arkansas, kind of an exciting going forward, our state legislature did vote in the last session to establish or investigate the establishment of a state-based marketplace. So Arkansas has appointed a new state-based marketplace board, and they are beginning to look at the potential of transforming no sooner than plan year 16. So that's a little of what we have on our plate.
So Sabrina, you're in the fortunate position of having a bit of a bird's eye view. Can you tell us a bit how you see the status of marketplaces nationally, with a particular focus maybe on the federally facilitated marketplaces, and what you see as the most pressing priorities for marketplaces in the coming year?
Sure, and thank you, Claire. And really, it's a thrill to be here. It's a thrill to be here every year. One of the funnest things I do in rather mundane life. I am acutely aware that our panel is what is standing between you and a free drink. So hopefully we're going to try to make this as interesting as possible. One way I'm going to try to do that is to share some breaking news. For those of you, maybe some of you have caught it on your smartphones today, but if you've been caught up in workshops and panels, there's some really exciting news out of Missouri. Some of you may have seen that the federal court has struck down Missouri's navigator law that severely restricted navigators' abilities to do their job. There's actually somebody here, her name is Ingrid, in case you bump into her. She's part of the plaintiff's team on that litigation, and she was telling me a little bit about that court decision, and it's a really terrific court decision. The judge basically said that any attempt by the state to regulate the conduct of assisters acting on behalf of the federal marketplace is preempted. It's a broad decision, and I think it will have a national impact in these other states that are attempting to regulate navigators. So great news to share with all of you today. In terms of where things are at nationally with the marketplaces, I think it's for a while yet, it's going to be all about enrollment. And the good news is, we had that December surge in enrollment that people were predicting, and it did happen, and we've got some great numbers to show for it. And anecdotally, what I would say is what I'm hearing on the ground in federal states as well as state-based marketplace states is that that surge of interest is actually continuing at close to the same, if not the same level of interest right into January. So I think those January numbers are going to look actually pretty darn good. The other interesting trend that we're seeing is we are seeing that state-based marketplaces, perhaps not surprisingly, but I think an important thing an important observation is that state-based marketplaces are outperforming the federally facilitated marketplaces. The Kaiser Family Foundation did a terrific study looking at the states enrolling, what percentage of eligible population are being enrolled. And if you look at the highest performing states, 8 of them are state-based marketplaces. If you look at the 10 worst performing states, 7 of them are federally facilitated marketplaces. So it's clearly being borne out that the states that are embracing reform are doing a pretty good job getting people signed up. There are some anomalies, right? We have some states that are having, state-based states that are having, still having difficulties with their IT systems and their websites, but I do believe that given the commitment of states like Oregon and Maryland and Hawaii and Massachusetts to reform, I think we'll see those technical glitches work themselves out, and they will end up getting the people that they need into the marketplace. The other thing, and this is a little bit of a back office kind of wonky issue, but one that I think will have important consequences for the success and sustainability of the marketplace is this back-end IT. Some of you probably never heard of an 834 and 820 form before this fall, but we're now sort of part of our regular discourse. But the 834 is what's telling those insurance companies that, Joe Smith has signed up for your plan and he's got 3 kids and this is their subsidy. And there's been some problems with those. I think they're getting worked out, but the next step is the 820, which is basically the check that the insurance company gets from the federal government that attaches to your, helps support the premium. So getting that fixed is really important, not just from a consumer perspective, but from a long-term sustainability perspective for both the marketplaces and for the carriers. So.
Thanks so much. So now let's talk a bit about the consumer plan enrollment experience. Our ability to optimize this year was obviously hindered in many places by technical issues, but beyond just making sure that technical problems are solved, there is a lot that marketplaces can do to make the consumer shopping experience easier. For example, I think one thing we learned this year is the importance of allowing window shopping. So being able to actually see your plan options before you go through the eligibility process. And we also have a growing body of research looking at how to best display and manage plan options so that consumers can make good decisions. So I was hoping that each of you could talk from your perspective about what you've seen as strengths and key lessons from the marketplaces this year for how to best help consumers select and enroll in a plan, and also what you think the next most important steps are towards this goal.
So I think in California, I mean, there's first like just the logistical, does it work? And then there's then once it works, what kind of experience does it provide? I mean, I do think that even in California, we have issues about does it work? I mean, there are some glitches, and not just the online, but the in-person thing. So like on the call center, our customer service goals for world-class customer service that we wanted to provide in California was that 80% of the calls would be picked up within 30 seconds. The average in the last month has been 45 minutes wait time to get through. And so that obviously, we need to deal with that. Now, there's a Covered California board meeting going on as we speak, and they just announced that they're going to hire another 350 people in Fresno to beef up that call center for the next several months. And so, we're trying, but that's also a problem because if those call centers are sort of swamped with just people coming in, then they can't actually do what we wanted them to do, which is to follow up in the leads that the outreach and education people had been building. And so those leads are sort of sitting in a box because no one's taken advantage of them. So we just have a question of scaling the capacity, which is an issue. But once people get through to it, what is this, the system? And again, I mentioned the standardized plans, which we think is just huge in terms of a real benefit to consumers, not only to instill competition between plans, but also to make it just a much simpler process for consumers to make comparisons between, so that the Aetna, not the Aetna plan, but the Anthem Blue Cross plan and the Kaiser plan and the Blue Shield plan are the same if they're in the silver tier or whatever. I think that there are some other things we can do about plan design in that regard. So one of the things is we do have some plans in the insurance, in Covered California that are co-insurance, which we think is confusing to consumers. There's a little bit of a buyer beware. It says, oh, that sounds great. I'll only be on the hook for 30%, but then 30% of what? If that's a really big bill, that could trap some people, so we want to move away from that in future years. And then in terms of experiences, one of the things that, because we standardized the benefit package, we actually are hopefully having consumers to then move on to other actually more relevant issues in their buying decision, like the network, like quality. So having quality ratings and having a good and functional provider search tool. California had our provider search tool did not work when we first started. We finally were able to get doctors up in like November, December. We just added hospitals and community clinics in the last couple of weeks in the provider search tool. So, those are things that I think are just critical because, again, now that we're removing the confusion of the complexity of benefit design, then we can actually focus on some other things that consumers need to make their choices about.
Thanks, Cindy.
Well, again, we were using the healthcare.gov federal enrollment, But I have to do a little sidestep first and talk about our Arkansas private option enrollment, because Arkansas never had Medicaid managed care plans. It was all fee-for-service before this. And quickly, when this was developed, or the law was signed in April, our Medicaid agency built a shopping experience, and we had to get people to access Arkansas. We wanted them also coming from the federal marketplace, but because there wasn't the smooth transfer of files from the marketplace to the states, that became a problem. So we had one thing that really helped with enrollment on the private option side, and that was our state use SNAP facilitated enrollment. So many people had a letter, they were SNAP eligible, that said you may be eligible, or you are eligible, are you interested? They had to affirm by sending back in a card. They then had 12 days to go to the state portal and shop, choose a plan. If they didn't, they were auto-assigned, and they had 30 days to switch plans. So doing that, that is how the bulk of our private option enrollments have occurred, and we have probably 85,000 enrolled in private option out of hopefully 250,000 in that expanded Medicaid market. I think we have a way to go in the whole eligibility enrollment. Anything we can do to improve the online experience, anything to give the consumer confidence that this is going to work, that they're going to get enrolled, is going to be important. We can see so many more people determined eligible than have enrolled, and that tells us that we have a gap there and a way to go. We really need to smooth that Medicaid FFM transition and truly move toward the no wrong door we all had wanted in the beginning, but to smooth that, eligibility is going to be really important between the states and the feds. I think we still have to look in the future not only at standardizing plans, but just simplifying insurance. It's not simple, it's complex, it's hard for consumers. And I think what we've been hearing and seems to play out for us is that provider, pharmacy, and out-of-pocket expenses are the big ones. And now we have this move to go to health savings accounts, and that's going to be more complex. And there's a lot the consumer's going to need to understand. So that we had phones and we had phone banks working, and that we had our on-ground, what we called guides, our in-person assisters, made a really big difference. I think another issue going forward is going to be the EHB only plan, and if there's any variation, how is it going to be? And we're not sure how the feds are going to want to do that. And if there's shadow plans, then I'm really concerned there could be many, many, many choices for consumers, which could lead to confusion and non-decision making and shutdown. We're all waiting kind of for meaningful quality. So I think what you all as advocates can help us the most with is continuing to do research, fund research, find out what's working, what are the needs, what are the barriers, what are the facilitators, keep disseminating that information in an independent way. And I think that's very helpful. It has been for us.
Sabrina. Yeah, I mean, I would wholeheartedly concur with what Cindy just said. Generally, what I'm seeing out there are that, huge educational challenges. Obviously, I think there was a survey recently that said that close to 70 or 80% of people don't even know that financial help is available to them on the marketplace. But then even when they get to the marketplace, they often don't know or are overwhelmed by what they should be looking for, what they should buy, what the right plan is. And it's a really important financial decision for any family, but the process is really confusing. As Cindy said, it's a very complicated process. So there are some marketplaces that are trying to make that experience easier for the consumer. California is certainly one, and we did a study on behalf of the Commonwealth Fund recently and looked at the state-based marketplaces, and we found that 9 of them have taken action to restrict or limit the number or types of plans that can be offered at the various actuarial value tiers. And of those, 6 have also done some standardization of the cost sharing and the benefit designs. Again, that's to try to help people make true apples to apples comparisons among their options. But it's going to be really important as we go forward to do some real market research about consumers' experience, and sort of at each point or decision-making point that they make during the transaction, what is happening to them along that chain, and do things like focus groups and surveys and other kinds of things to figure out what is the optimal way to display this plan information in a way that consumers can make the best decision for their health care, but also for their pocketbooks. I'll just say, props to Massachusetts, because I think that state is the model for a lot of states and how to do that, and that was largely in response to consumer feedback that the choices originally displayed on the Commonwealth Connector were just sort of too overwhelming, too confusing for folks, and so they did try to restrict those choices. So there's pretty good evidence that doing that works for consumers. And I'll also just say in closing that when we did this study for Commonwealth, we were looking at the state-based marketplaces, but bear in mind that states that are doing plan management in a federally facilitated marketplace have the ability to standardize or other set requirements for health plans, or limit or restrict the kinds of plans that are offered at various levels. So there are opportunities in those states to encourage state officials to make the consumer experience an easier one.
Thanks, Sabrina. So I think we'll continue with you and talk a bit about provider networks. Obviously, there's been some information barriers around the country about which providers and hospitals, et cetera, are in networks. And also, since we are still in really enrollment stages, it's hard to know right now how consumers are faring in the networks, but there have been some concerns throughout the country about ensuring that the marketplace networks are adequate. So if you could talk sort of generally your perspective. I know you've done some really good research on this issue about what states are doing. What do you think has been accomplished so far? What do you think the top priority fixes are that we need to improve the situation, and how can advocates be involved and help?
I'll try to answer that very briefly, but there's no question that insurers pursued a strategy of narrowing their networks for the 2014 plan year, and largely it was to try to keep prices low. It was a lever that they could pull to constrain prices on the marketplace, and it was really a competitive strategic business decision that they made. There was a McKinsey study that came out recently that found that approximately 70% of the qualified health plans on the marketplace have narrow or ultra-narrow networks. And that survey defined narrow around the access to hospital-based care, and I think that is sort of the first issue that's emerged, and there are, at this point in time, real reports and concerns that in many areas, particularly rural areas, people are going to have to travel a fair distance to get care at an in-network hospital. This is a real serious issue for consumers, particularly because under the ACA, there are these caps on your out-of-pocket spending and under your benefit package, but those caps do not apply if you're getting any care out of network. So there are real pocketbook concerns for consumers. I'll just say, in all candor, I think that many state regulators maybe didn't quite expect that this would be, and I'm sure Arkansas was totally on top of it, but I will just speak generally, that I get the sense that many states, there was not much of a review process in place. And the problem is, so the good news is, for the first time in the ACA, we have a national expectation that all of these marketplace plans will have an adequate network. The bad news is that the decision as to what constitutes an adequate network was largely left up to the carriers. And states really didn't do much of a review before they certified these plans for the marketplaces. I think that's going to change. I think a number of state legislators and regulators have said, hey, wait a minute, we need to keep an eye on this and make sure that there are providers in the network that can deliver the services that are promised under this benefit package. So I think in a number of states we are starting to see some bills. We are starting to see regulations moving forward on this network adequacy issue. But I think as consumer advocates, it's really important to remember, oftentimes these network adequacy fights are big fights between the providers and the carriers. And they're these sort of turf battles. But from a consumer perspective, there are real trade-offs depending on what direction that the state ends up going. And there are price issues when you require the broadest possible network. So important trade-offs that consumer advocates need to consider and think about in terms of an approach to network adequacy.
Go ahead.
I think in California, this has gotten a lot of attention, and as the trade-offs are, just to pick up that point, I think we want people to have access to the care that they need, but we need to change the question, because some of these are driven by the provider. Some of this is driven by opponents of the health reform law. Some are driven by the providers because they want to be in the network in some cases at fairly high rates, which then raises the rate of the premium. There's one noted hospital in LA that serves the Beverly Hills crowd that if you include it in their network, that some folks have calculated that raises the premium by over 10 to 15%. And so then the question is, is it really of value to include that hospital in the network if it doesn't have any better quality outcomes, and is probably not where the bulk of the covered California enrollments is not in the neighborhood of where most of the folks that we're seeking to go are going. I think we need to change the question about whether it's a broad network or narrow network, because I'm not sure that how many consumers actually care if they have 2,000 doctors in their network versus 4,000 networks. They want to know, is their doctor in the network? So you need to have the provider search tools readily available, but two, you need to make sure that regardless of what exact number the network is, it meets this basic criteria, this basic premise and promise of managed care, that if I'm, as a consumer, accepting a limited network, that network is adequate enough to provide me care when I need it, where I need it, in a timely manner. So in California, a bill that we actually passed over a decade ago and that we got implemented more recently tries to set this as a timely access standard. Can you get an appointment within 2 weeks? Within 10 days, 10 business days, can you get an appointment with a doctor, with a specialist, and that be the barometer, which I think actually makes more sense for consumers than, again, sort of these other metrics that seem a little bit more illusory. And if you can make that guarantee to consumers, then I think consumers will feel more trust about, okay, I'm willing to accept this. If they're willing to make sure that I get into who I need to get into, not necessarily every doctor under the sun, but if I can get in a timely way, then that I can do it. But let me the last point here is that we don't want to undermine the principle of negotiation. We strongly support the notion of an exchange negotiating with the insurers and the insurers negotiating with providers for the best price. And so we need to make sure that is coupled with strong consumer protection, and that obviously needs to be done at the state level, either through the exchanges contracts with the insurers or to set up the qualified health plan standards, or by the regulator, your Department of Insurance, et cetera.
So Cindy, how is this playing out in Arkansas?
Well, we learned a lot the first time around doing our certifications. I'll start with saying that when we had our new healthcare independence law, which was the private option, and it was signed in April, we delayed our requirement for applying for QHP status, or even for new carriers coming into the state for simultaneous review, until June 30th, which gave us a month to do all our reviews because they were due at the feds July 31st. So what we learned in this was that we were not as prescriptive probably as we should have been with the plans. They were thinking they were going to tell us how the networks were. We had one dominant carrier, made it harder for new ones to come in quickly and establish. So we had a little leniency in the first year, but we also learned that we need to have very measurable guidelines, meaningful guidelines that we can measure and then measure them. And so during this year, a subcommittee of our Plan Management Committee, our Network Adequacy Committee, has been meeting. So the plans, some of the hospitals, the federally qualified health centers, behavioral health providers, our advocacy groups have been meeting together. And so next year, they will submit their geo-access maps. And we will have time and distance requirements. We'll want to know not only primary providers and specialty providers, but primary care medical homes. We are going to move toward more later, I guess, on wait times. I don't think we have that in for this year, though it's on the radar screen. So we'll get more out, we'll ask for more, and then we'll need to monitor it. And so I think that's a big lift for us for the next year. Something that complicates, so we haven't had much of the narrow provider experience yet, though we have had some. We've had some investigation of some complaints by the healthcare providers. Seems to be things are okay right now, but we're really looking forward. But Arkansas is any willing provider state. So you really do have consumers that could go out of the network and then have high bills, and those out of the network costs don't count toward their out-of-pocket expenses. So we're making progress, and we have a ways to go, but I think we're on the right road to getting something measurable, getting started, monitoring it, improving.
So another really important ACA protection regarding the marketplaces is the availability of accessible marketplaces regardless of what your primary language is. And this has definitely been a challenge to implement in the first year. So I was wondering if you all could speak to how you think that did go this year from where you sit, and how you think advocates can be involved in helping this get better next year.
So, I mean, so in California, this is, you know, as much as there is things where we've done well, this is an area where we had some work to do and still have some work to do. The numbers that I relayed before, you know, unfortunately, I think, you know, we're a little bit, we're more than a little bit low on the Latino enrollment side. It turns out to be about, of those who declared an ethnicity, it was 15 to 20% of the folks who enrolled were Latino, and Latinos are probably in California about half of the uninsured population. So it's a pretty big gap, and the number is 5%ish for Spanish speaking. Some of that was because of that. Frankly, the systems weren't ready. The Spanish website had significant web issues and actually continue to do so. They're working, they're fixing it. You know, lots of times you'd be on the Spanish website, you click a link and it goes to the English page. You know, things like that. The paper application was not ready until December in Spanish or in the you know, the over a dozen other Medicaid appropriate languages that is required in California, and so that, you know, was a hindrance. And then you know, frankly, the point is, do you have the folks who are doing the enrollment that are able to speak the variety of languages? That, you know, do you have the call center? Do you have the people who are multilingual at the call center? Do you have the community enrollers? We had a goal of 10,000 community and assisters, community enrollers. In October we started with 300. Now we're around 3,000, 4,000. We obviously have a ways to go, and that's a main way to get to those folks. But obviously it's a priority, but it's obviously a huge priority. There's a lot of efforts to redouble efforts in California, and there's some things that need to be addressed for the next round in the end of the year. But it's ongoing work. But it shows that this is a challenge, even in a state which has the right motives and goals, and is not trying to that this is not easy, but we absolutely have to address it.
Well, this is our good news, bad news story. Our website was great. It was completely in Spanish, updated every day in Spanish. Everything was in Spanish, and we were so happy. But when we lost our contract the day before open enrollment, we no longer have a Spanish website. It's no longer updated. We had a contract for Street Reach, Latino Street outreach by experience group from another state. We had problems because it was an out-of-state contract, and then the contract ended, so we had no specific street outreach. We have asked our guide organizations to have bilingual guides, which some do. We have one of our navigator organizations that specifically has hired Hmong, Spanish-speaking, and Marshallese. Arkansas has, besides Hawaii, outside the Marshall Islands, the largest Marshallese population. We've met with the Princess. Our Arkansas Advocates for Children and Families has done a lot of work around that population. So we have pockets, we have ability to translate. I've said many times the federal website has 150 languages. I haven't really had anybody say it's a problem or it's not a problem or we couldn't get what we needed or we did. I'm thinking because it hasn't bubbled up as an issue, it hasn't been as bad as it could have been, but I know it hasn't been as good as it could have been. I really think the plans need to be in Spanish and in other languages too. I don't know that we've done anything like that. So we'll do our best to continue to translate, do that in a way that's meaningful, have translators, have people available. And I think that's another thing that consumers can help really bring to our attention. Where are these pockets of populations? Where are where are we missing the mark? And complain. I mean, help lodge complaints with the state or with the feds, or let us know if it's not getting remedied, because it's very important and it's something I think we'll need to do better.
All right. So Sabrina, you've provided invaluable support to advocates in DC, but also to advocates all over the country trying to influence policies in the marketplaces. And you've done that for all states, but I think you've also provided a lot of important perspective about the federal exchange, where the levers for advocacy are a bit different. So if you could just talk about tips you have for everyone, state exchange, partnership, but especially when you're in a situation where you're also really focused on influencing federal policy as well.
Yeah, sure. It's tough. I think the opportunities for advocacy with the federally facilitated exchange are not the same as they are with state-based. You don't have those formal mechanisms like an advisory board, board of directors or an advisory committee that is a clear avenue to participation for consumer advocates. I know that there was outreach to stakeholders that the feds did conduct, but I think some of that was frustrating for advocates in terms of the meaningfulness of those kinds of calls and meetings that were held on a regional basis. I would say, however, that first of all, when you think about the structure of the FFMs, even in a fully federal exchange that's not necessarily a partnership, the feds have been pretty deferential to states, at least on the plan management side of things, so around the certification of health plans, around the oversight of health plans. Even on things like network adequacy and other things that have been traditionally state functions, even in those FFMs, the feds have said, well, if it's something that the state has traditionally done, we will just totally defer to that. So that is, I think, an opportunity for state-based advocacy. So get to know your insurance commissioner, or if you're in a state where the network adequacy is done at a different department, get to know the folks in that department. The other thing is, remember, when you're dealing with your insurance commissioner or other state agencies, you are, because particularly those of you who are with community-based organizations, you are a really critical voice for them to hear from about issues and problems and systemic challenges that consumers are facing as they work their way through the system. Certainly now in terms of problems that they might have with accessing a provider, or the plan said such and such was covered, but then they didn't pay my claim. All those kinds of things are things that you all will be hearing from the communities that you work in, and really important information that you can provide to state officials and state regulators. So it can be and should be a two-way street, where you're playing your advocacy role, but also providing an important source of information about how consumers are faring.
Thank you. So Cindy, you're actually in the exchange director seat. So what advice do you have for advocates about how to be most effective in advocating for consumer-friendly policies?
Well, you all know this, but everything's about relationships. So, find out, have your information. Stories are great, that people hear them and understand them. Know the marketplace regs the best that you can, and what's needed to be changed, and then know the process for change, and know where the decisions are made, and work to be at those decision-making tables. So for us, when we receive written comments, that's great, but it's really important that you make an appointment and go in and meet somebody and talk with them too. Present information, help do the research, develop the relationship. Collaboration, it takes trust, and it takes a while to build the trust, and it takes a while you got to be the leader sometimes and the follower sometimes, and you've got to be persistent and know when to push and when to fall back, when to take less than what you want to get the bigger goal. We had something in the last year where there are some meetings where it might be best as a first meeting if the advocates aren't there. We had situations where the plans and the healthcare providers weren't talking to each other, and I don't think they would have with others in the room. So we had to have first steps of just having the information out, the facts out, and assure the advocates that the decision making is where you're at the table. This is all going to come before the right committees, but let's have these meetings first. And it took a while to get the trust there. So sometimes there may be reasons, but ask questions. I would say know who your allies are, get support, even if it's out of state, find allies or support national groups out of state. Find out what's worked for other people. I think really if you can come as advocates solution focused, identify the common goals, and be persistent. Know you're going to be there, going to continue to be there. And this has been a long haul. I never thought we would get this far. I've been telling people in my lifetime, but I would do it over again, and we have a long way to go still. But I think that the advocates have and will continue to make the difference. Talk to your policymakers, talk to your legislators. Our insurance commissioner happens to be a very consumer-oriented person, and he was a legislator for a long time. But the first question he asks is not about what's going to be for the insurer or for the healthcare provider. It's always about the consumer. And so I think be sure that you're speaking for the consumer, and that's what we're about. So those are some of my thoughts.
Thank you. So Anthony, being in a state with its own exchange, what have you found key to working with different decision makers, whether it's your marketplace director, your board, the insurance department, the Medicaid agency? There's a lot of people involved. So what have you found to be the key to really being an effective advocate in that environment?
Well, I think the first thing is that you want to have the tools as an advocate, which is, as public and transparent a process as possible. I think that's, really key. I think when we set up the exchange, we had public meetings. So, for example, for those of you who don't find us totally scintillating, you can go on the website right now and watch the Covered California board meeting as it is. I'm not recommending that now, but if you go to www.hbex.ca.gov, is archived all the board meetings from the last 3 years. And so if you want to see, at least how California is doing it, for better or worse, and all the board materials are posted as well. And that creates a process. And I think actually, to the extent that places like California and others have had maybe more success in, the federal process, which has been a little bit more of a black box, I think that's been one of the reasons, is because we've been able to point out problems before they happened. And I think that's the second piece of how to frame the advocacy is especially if you are advocating with somebody who has the same goals and the same good intentions. I know that's a shock to people in the room that sometimes people with the same goals and same intentions don't agree sometimes. But if you are advocating, then the question is, how do you frame it? It says, we are trying to help you. This will go easier if you do X. And I'm not talking about that in the New Jersey Chris Christie kind of way. I'm talking about it that if you, this will go easier because this will solve some of your problems. And so, for example, if you know, one of the things we didn't get, for example, is we wanted our state to be a premium aggregator, somebody to have the functionality of collecting premiums. And the way we tried to frame it was, this will make the issue of dealing with the unbanked, the dealing with, you know, those folks who don't have bank accounts, how do they pay their premiums? This will deal with some of the other logistical issues simpler for you if you do this early on. Now, in response, they were like, we understand your argument, but frankly, we're in a moment of triage. We have to focus on these core elements. We just don't have the bandwidth to take this on. That was a fair argument back. We didn't agree with it. It did create issues when we did do it, but you know, that was the dialogue. And so, you know, we do have issues where there is a triage and issues have been pushed back. And so I do agree with certainly the persistence argument, which is, you know, if you don't, there is opportunities to revisit some of these things, and I do think that we will be going back and revisiting some decisions that covered California. Covered California originally made a decision not to publish quality ratings in the beginning. Then after people continued to press, they said, okay, we'll try to put something out because something is better than nothing to give consumers some guidance. And then another example is just on network adequacy, where we think that it, you know, should have been included in the contracts. So that you know, we can make that sort of broad statement to people who are concerned about the narrow networks. But again, if there is a triaging of issues, that gives you a second and third, because this is a long-term relationship that you're building with not just the marketplace, but also with the regulators, also with the state administration, and the more that you're in different teams, even if again you occasionally disagree.
Thanks so much. So we do want to make sure that there's a good amount of time for question and answer from the audience. And there should be cards on your table, or if not, feel free to write on a piece of paper. And then Lydia from Families USA, and maybe I can volunteer Cheryl to help pick up some questions. And so as you do that, I will ask about one other thing, and that's quality measurement. Quality ratings for health plans are required to be available on exchange websites in a user-friendly way. This was a provision that was going to be implemented a bit earlier, but in terms of when it absolutely has to be implemented, there's been a delay by the feds until 2016. But we have seen some states already implement these kind of measures, and more will hopefully continue to do so. So I was just wondering if you could reflect on where we're at with that, and you know, how you think that is a priority among other priorities in your state.
I mean, I'll just say generally, again, as part of this Commonwealth Fund research that we did last summer, in spite of the fact that the feds delayed the quality-related parts of the QHP requirements, a number of states did decide to move forward, and we found that 9 states decided to display quality data by 2014, and that 10 of them decided to move forward with a quality rating system ahead of the feds. But you know, as Anthony alluded to, you know, I think those were decisions that the states made from a policy perspective, but there were sometimes that's easier said than done, both from a functionality perspective, but also some real and legitimate concerns about, you know, you don't want to display data that's just not meaningful, particularly when you're talking about brand new plans that haven't been in existence before, brand new provider networks. And there were also real concerns about new players and others who, you know, might be disadvantaged by other carriers that had been in the marketplace for a while. So, like some of the new co-ops and other new market entrants, new companies that were coming in, and how they might be perceived if they don't have the same kind of quality data. So, and I think this is an issue that played out in almost a really fascinating case study out in California, because it was something that your marketplace was really committed to, but there were complications along the way.
Right. I mean, part of it was, as said, I mean, I know it will shock you that the insurers who got good ratings wanted to include the ratings on the website, and the insurers that didn't have such goods didn't. And part of the argument was, as Sabrina said, that they said, well, these are based on different networks. But again, we thought something was better than nothing. We also thought that it reflected the philosophy of the company. Even if it's not exactly the same network. And let's be honest here, it's not like the networks have been preserved in amber up until this point. These are. These networks are constantly changing. Doctors are going in and out of them as well. And so if you're going to wait until the networks are exactly the same in order to publish a quality rating, you will be, waiting for Godot. So I think, moving forward, we did have our own issues because California always wants, doesn't want to rely on CAPS or national data. We want to have our own data because we have, different standards. And so we're working to evolve that. But it is a process of, what is the long-term goal and what are steps in between. One of the final things I'll say about quality is that the other place you can influence quality is not just through putting a mark on the website when people are choosing, but also through the contract with the providers. And so again, that was something that we tried to go aggressive in year one. The insurers pushed back, and so in the first couple of years, what we're asking the insurers for is a lot more data, a lot more transparency about quality, with the intention that that in like a third or fourth year of the contracting process, there will be some standards with regard to quality if you want to participate in Covered California. But let's get the data first. So again, some things of what's the end goal and how do you get there?
Well, we're behind California, but I think this is what it is about. This is the most exciting to me, the whole quality thing. It may be 5 years, it may be 10 years, but consumers, when given information, and it's the right information, we've got to know what is important to consumers. We have to figure out how to meaningfully present that in an understandable way, and then educate consumers to make choices, value choices, and that is where this is going. And where we are is operationalizing, getting the data. We're looking at APCD, All Payer Claims Database. We're looking at how do we cut down duplicative reporting or burdensome reporting, because it's not just our marketplace. We're looking at Medicare, Medicaid outside. We're looking at some other plans. Even a big self-funded Walmart has interest. So how do we get everybody in? What are our metrics that people can agree on? Which are the right subsets? Then how are we going to analyze those, make meaning that is meaningful for consumers, which is what it's about. So I think that it's going to be like the shopping experience, that if we have too much or the wrong quality reporting out, then we're facing the same overload, shutdown, non-decision making. So I don't think we know the answers, but I think it is the key, and this is where we have to go. So I'm glad we have people to look to that are ahead of us. But we have a quality subcommittee of our plan management, and they're going at it. So I think we will be ready after the federal SEC comes down, and we'll have what we think is important, and we'll have a process beginning to make it real.
We received, I think represents a universal problem that's been alluded to. It's fairly easy to get an SBC, a summary of benefits and coverage. It's easy to see some basic descriptions of cost sharing, but it gets harder to really understand how a given plan is covering specific benefits, whether it's visit limits or cost sharing for certain services that aren't on the SBC. And so this has risen concerns obviously of transparency of information, but also questions of enforcement. How do we know the plans are really complying with the essential health benefits benchmark in the state? So if you could sort of reflect on that in any way that we could work to improve the access to the information in the future, I think that'd be helpful, probably in every state, no matter what kind of exchange you have.
Well, it's pretty early to tell, but in our first month, we've had complaints about behavioral health benefits implementation. And when we were doing our reviews, every plan, we had what's called objections back to the plan about their definitions and how they were doing that. We were bringing them into parity, and they really hadn't been before. So that was one where we are now reaching out to do follow-up to see that what in fact needs to be happening is happening. And I think it's going to take monitoring, some routine planned, some random, some consumer complaint driven. You know, track the complaints that come into a consumer assistance program or whatever, and use those to guide where we need to do auditing. So I think that it's early on, but the main monitoring and taking action will be the main remedies.
I would just have two quick points on that. First of all, on the SBC, the Summary of Benefits and Coverage, what we have been hearing, and I would just, if she's here, give a shout out to Lynn Quincy at Consumer Reports, who's been doing some great work on the SBC and how it's structured and how usable it is for consumers. But these forms, unfortunately, are not being filled out in a uniform way like they're supposed to be, and they tend to be riddled with a lot of inaccuracies, which obviously makes them less usable for the consumer. And states can, of course, do an upfront review of those SBCs before they're put on websites, but there is a real capacity issues for the state departments of insurance in terms of their ability to go through and crosswalk with what's actually covered in the plan. And then on the back end, the post-marketing stuff with the the monitoring and kind of enforcement that has to go on, that's a critically important state-based consumer function of insurance departments. There's only a very small handful of states that have deferred enforcement or delegated enforcement to the federal government, only 5 states. But unfortunately right now, it is not easy for a consumer to figure out if they do have a problem, where do they go? So if you're in a state-based marketplace, do you go to your marketplace? Do you go to your insurance department? If you're in federal marketplace, do you go to the feds? Do you go to your state insurance department? If you're in a group plan, do you go to the Department of Labor? And then are these agencies even talking to each other to share not only the information necessary to resolve a particular person's problem, but also to try to identify where there might be more systemic problems with a particular insurance company or across different insurance companies. So that is an area where I think there's still a lot of work and collaboration and communication that needs to happen between state entities, but also between the state and the federal government. And I don't think we're there yet.
Yeah, and I mean, I think there obviously needs to be more work on just explaining to folks what these different tiers mean. I'm no less a healthcare expert than David Letterman was trying to describe this, and he was like, there's the silver plan, there's the gold plan, and there's the platinum plan where you get to drive the ambulance. And it's an okay joke. I think it's actually funnier that David Letterman is now making actuarial value jokes on late night TV. But I think but I do think that there is this tension, as Sabrina mentioned, about the regulator versus the marketplace. The marketplace is very clear in California. It doesn't want to be a second or third regulator. At the same time, we do want it to be, for those of us who don't work for large employers, who don't work for Google, the HR department for the rest of us, the thing that provides that sort of good housekeeping seal of approval that, you know that the plan is vetted and it has some basic standards. And I think that there is a more role that the exchange can use, that doesn't take the place of the regulator, but it has a complementary role, and we're all still trying to figure that out exactly.
And I think I should say after listening that another context for my comments is that as a partnership, we are operating out of the insurance department, the regulator department, and so the new state-based would be a private or a not-for-profit quasi-governmental board outside. And so developing all those relationships that you've had to do about it, who does what, is something that's going to be an interesting focus for us going forward.
So the next question is, how are QHPs complying with the non-discrimination requirements from Section 1557? And I would add, how are regulators overseeing compliance of the non-discrimination requirements when it comes to coverage exclusions and specifically LGBT-friendly provider networks? a lot of work to do in this area, but initial thoughts. I think we've all been concerned about this.
We published a paper out of Georgetown on this issue, and on the non-discrimination provision, this is one of those things where I think there still is a building of capacity, building of expertise process that needs to take place on the regulator side, on the sort of upfront review. In terms of post-marketing issues, in other words, now that these plans are actually in the marketplace and being used by consumers, I don't think we know yet. I would defer to you and see whether you've had any issues coming up through your department, but I have not yet seen any analysis or any review of how consumers are actually experiencing their benefit packages and whether they're experiencing any discriminatory impacts.
And I'm going to again say it's probably early on. Do the best that we can in reviewing them when they come through to look for any obvious design flaw, but then until we have consumers and we have some data to look if some design is discriminatory in some way that we didn't pick up early on, I think it's going to take time.
This has been an area of excitement in California and a couple of other states. I don't know, Kate, can you raise your hand? Kate Birch is with Health Access, but she's also the director of the California LGBT HHS network. And working with groups like the Transgender Law Center, they were able to secure in California, a non-discriminatory ruling about plans treating. Providing coverage in various circumstances that's important to the transgender community. That was really important. I know other states like Colorado have just adopted that, and so there is progress in this. And it is, I think it obviously is good. Some of this is going to be state by state, but both the regulator and then the enforcement on the insurers. But it is an exciting time to have that philosophy of non-discrimination that is infused throughout the Affordable Care Act. This is probably the biggest anti-discrimination law that has been passed in many years, whether it's against women being overcharged with regard to benefits, with regard to pre-existing conditions, or everything else.
Thanks. So there was mention repeatedly of the importance of standardized plan or the benefit of having standardized plans, but what should those plans look like? So what are elements of a good plan if you were to pursue a standardized plan that every issuer would be offering in your marketplace?
We certainly are not going to say that California is perfect, right? But some elements that we like is the fact that a lot of stuff is pre-deductible. The more stuff that you can put pre-deductible, so it's not just the sort of that bare sliver of free preventative care, but to the extent that primary preventative care in the broader definition is pre-deductible, so it almost becomes like a hospital deductible. In those silver plans that have like the $1,000-ish deductibles, and then those bronze plans that have those $5,000 deductibles, you want to have folks be able to get the primary preventative care that we encourage people to have, and that also would be seen as more of a value for sort of the young, healthy person, rather than something where they don't get any benefit until they really are in a high dollar care situation. So I think that's one philosophy. And then I would just reiterate the point I made earlier about really beware of out-of-pocket costs, especially when we're dealing with and out-of-network costs, especially when we're dealing with a population that is under, or the target population is under 400% poverty level. These are not folks where out-of-network is a real viable option. If they're already sort of spending a lot of the percentage of their income on premiums and the cost sharing that exists. And so, again, we're very wary about structures like co-insurance and would like to move away from that.
I can't add to that except for taking it to the consumer education piece. That is all very complex. So we can build good benefits and plans, but at the point of buying, do I know that this kind of deductible and this premium and this lower cost share for this kind of service, and how that's going to shake out to my individual anticipated health need, and make the right buying decision? How are we going to communicate that well?
Yeah, I would completely agree. It's actually a really difficult question to answer because health benefit package is a multidimensional thing, right? It's not just about the scope of services that are covered, it's about the cost sharing. And cost sharing, of course, comes in different forms, co-payments, co-insurance, deductible. But it's also about the network, right? And, do you want that tightly managed HMO or the more open PPO? And it really does come down to making those the trade-offs of the various choices that a consumer might have very clear, so they understand not that just the impact of that choice on their access to services, but on their overall financial security.
And I would say that's for everybody, not just formerly uninsured, because, what have we mostly taken? What has been available to us? And so I might have several choices of an employer-sponsored plan, but I think so many people that would consider themselves educated health consumers are not when it gets to looking at all these plans.
Thanks. And I'd like to mention Lydia Mitz, who's standing over here on this side of the room from Families USA, has been looking into some of the standardized plans and other plans from around the country that have done what Anthony described, which is try to provide some coverage before the deductible to make sure that people are getting certain services, even if they haven't spent a lot out of pocket yet. We've seen such wide variation, I'm sure as you all have too. Within one metal tier, you can have a very huge range of deductibles. And in some states, they're all pretty high with not a lot of those types of options that Anthony described. So I would recommend reaching out to Lydia L. Mitz at Families USA if you want to share plan examples, and she can show you what she's found through her initial research. And we plan to continue to work on this issue throughout the year. So for our next question, this is specifically for Sabrina, but I think it's really for anyone. What is the prospect for more active purchasing in state-based exchanges? Does it require a really competitive market to start with, for example, at least 4 or 5 issuers?
That's a tough question. As folks probably know, there was a minority of states that pursued sort of what's traditionally seen as the active purchasing model, a selective contracting kind of model. But I think active purchasing takes place along a little bit of a continuum. We have seen states like Arkansas and others that are really seeing their role as an exchange as acting on behalf of the enrollees, and that may include adding additional requirements to the certification process. It may include just sitting down and talking with the carriers that are participating in a more informal way to see if they can improve certain aspects of their performance. But yeah, there are a lot of challenges to effective active purchasing. You've got to have a critical mass of enrollees that are a desirable group of people for insurers to want to participate in the marketplace. And I think it's early days yet to know sort of state to state, market to market, how that's going to play out. I think that active purchasing is sort of one of these decision points that a number of exchanges have sort of triaged to, not a front burner decision point that they have to make. They're still busy not only turning the lights on, but making sure that the heating system and the electricity works and all those sort of basic functional things just to be up and running. So I don't actually know how many states that have not pursued some form of active purchasing are actively considering it for 2015 or beyond.
I think actually even after so a couple of things come with the decision of active purchasing. Like one of the other things that was in our implementing legislation is that once it decided to be an active purchaser, we also put into the law conflict of interest provisions for the board, so that nobody on the board can be part of the health industry, because if you are an active purchaser, you don't want the industry on both sides of the bargaining table. And so there are some things that if you go down that road, there are some logical things that follow from that. But I agree it is a continuum, and I also say even when you do decide, and I think that even whatever levers you have, whether it's full-on negotiation, whether it's a bid process, whether it's just what is the standards for a qualified health plan, then the question is, well, what do you do with that? In one of the early board meetings of Cover California, they had commissioned 4 concept papers of 4 ideas of what you could do with that power, right? It could be a low price leader. You could be focusing on sort of a quality, a comprehensive peace of mind products. You could be a driver of system reform and change for better quality, or you can be a partner with public plans for just mass enrollment. Now, what did we choose? Well, we choose all of them. Because obviously those are all values, but there is a weighting that goes on about are you going to focus on driving for the best possible cost, or are you going to have other values and focuses, for example, on trying to drive system reform or things like that? And that's something that maybe different elements of that might be of more interest to attract states to become more active, more selective contractors, more active purchasers.
One quick point that Anthony triggered a thought. I do think, a number of states in their Medicaid programs or in their state employee benefits program, are looking at ways to drive cost containment, higher quality delivery system reform, et cetera. And while there may not necessarily be sort of traditional selective contracting on the part of the marketplace, there could well be sort of an alignment of population health goals, quality goals, cost containment goals that can be transmitted across the public and the private sector programs, and also, frankly, partnering with large purchaser coalitions might be another opportunity for and a marketplace that doesn't necessarily want to label itself as an active purchaser.
So we have a question about marketplaces transitioning. So whether it's from a partnership marketplace to a state-based marketplace, or a federal marketplace to a partnership, or even a state-based marketplace, do you think there's a high chance of many of those transitions happening this year? Do you think there's an advantage to those kinds of transitions? What do you think we're going to see?
I don't think we're going to see a whole lot for the 2015 plan year, although there are, is anybody here from Oregon? I believe there's at least been some conversation about having the feds pick up at least the IT portion of the Oregon marketplace. So it's sort of a reverse of what anybody would have maybe anticipated. In Arkansas, planning for the 2016, right?
16.
Yep, 2016 plan year.
No sooner than then.
I believe there's been some legislation in Virginia to create a state-based marketplace, but I think the timing is really tight for a state to be up and running for that 2015 plan year. But they have until, mid-November to apply for establishment grants, is that right? And I believe the decision to make that transition happens in June. Am I right? They have to kind of decide by June. So we should know by June if any are going to take that step.
So this is a question that came up in a workshop earlier, and it's not an easy one, so you're not expected to know the exact answer. But basically, using your crystal ball, what do you think we're going to see next year in terms of premium rates? Do you think they're going to be similar to this year? Are we going to expect spikes? What would you do if you, your best guess, what would you say?
I don't know. I think it could potentially vary state to state. I will say that a couple of actuaries that I have talked to have said that we're probably going to see a little bit of a replay of 2014. There's frankly not going to be a whole lot of claims experience or sort of deep understanding of the population morbidity are in these marketplace plans, because rates do have to be filed fairly early in the 2014 plan year. So I think largely, and you're the DOI rep, so I should defer to you, but I think a lot of these plans, it's the same sort of unknowns that they experienced last year, right? Or curious what you would say.
Well, if it were just me, I would say they're probably going to look similar. What the plans are telling us is we can expect to see something go up, but I think we've got to see what enrollment does very shortly before they're applying again. And they won't have data yet, much to base it on. So I think we'll see very little difference.
I do think rate review is going to be important.
I mean, I think that I had the opportunity to go to the conference of the California Association of Health Plans to be a speaker, so, I listened into the other sessions. And it was fascinating to have, like, a couple of our major insurers, talk, and they were like, so how did you set rates this year? And they talked about, like, they hired all these consultants and actuaries, and basically, they just went with the small group rates because they couldn't figure out what the hell to do. So that's what they did this year. The guaranteed issue market in the small group. And so then the question is, what are they going to do next year? And I think different plans in California had different strategies. So we had one carrier who everybody thought was going to be the lower priced plan, ended up being above average in some cases because they were having sort of very conservative figures. We had another plan that actually was very aggressive, and especially in certain regions, and everybody's like, where did they come with those numbers? And so they're probably going to do very well in enrollment this year. And so I do think that there is, I don't know, I think we're not going to have the bump that we had this year because of the new benefits or the guaranteed issue. We will have the question of, depending on the state and even the region, there might be different variabilities. If we do really well in enrollment, then Covered California has a case to negotiate with them and say, hey, we did really good in enrollment. Let's see it. Let's see the fruits of that, as opposed to maybe in other states where the enrollment's bad and where there's an excuse to sort of to go up a little bit. But I also think that in a world where I think suddenly some of these insurers are in a new world where they are in sort of direct price competition in a way that they haven't been before. And so that will be a thing. And then I do agree, we're going to have on our ballot a ballot measure on rate regulation this fall. And so I think in California, they probably don't want to have huge price increases coming out in October before that November ballot measure. So that may be only a California-specific answer, I'm sorry. I would say the other thing I would predict is that I think that there might be some plans that, I was surprised at how many, the vast majority, like 90+% of the people who are signing up for the 4 big name carriers, as opposed to, there's 11 plans in California, but there's only 4 that are getting like the vast majority enrollment. So I'm hoping that the smaller ones stay in the game. I also do think that new entrants will come in. I think some providers and provider networks are thinking of, so why do we need the insurers again? And maybe jumping into the exchange by themselves, which might also provide some interesting competition that we haven't had before.
I'd like to thank our presenters, our respondents, Sabrina, Cindy, and Anthony, for sharing their experience and advice for us as we gear up for our Marketplace Year 2 advocacy. We hope you'll join us across the street at the evening reception. Thanks very much.